So hello everybody, this is the final video on beta blockers, and over here I'll be discussing all the beta blockers with additional properties. Now these are the beta blockers which I have discussed earlier, but I have purposely not discussed some of their additional properties with you. Okay, so let's start. There are two main additional properties, that is, one is intrinsic sympathomimetic or partial agonistic effect. And there are beta blockers with membrane stabilizing or local anesthetic effect. Now let's learn their names first. So again, there is this mnemonic, but this mnemonic I have not made on my own. I have discovered this on the internet. It was made by Dr. Ranjan Kumar Patil, and the mnemonic is like this: the beta blockers with intrinsic sympathomimetic effect, they can be remembered by CLAP, and those with membrane stabilizing effect can be remembered by CAN, blow, lamp. So you can remember it at one go, that is CLAP, CAN, blow, lamp. Okay, so the C here again stands for the two drugs together, cartolol, celiprolol. L stands for labetalol. A stands for acebutolol, and P stands for pindolol and penbutolol. Again, the C here stands for carvedilol. The B, all the capital letters, remember, stands for betaxolol. L stands for labetalol. A stands for acebutolol. M stands for metoprolol, and P stands for propranolol and pindolol. The drugs with maximum partial agonistic effect is pindolol, and the drug with maximum membrane stabilizing effect is carvedilol and of course propranolol. What do I mean by these terms? Partial agonistic effect. It means that it will behave as a partial agonist. I'm sure you have learned about partial agonists at in your general pharmacology portion. That is, they will stimulate the receptors and have a submaximal effect. Okay, so they will stimulate the receptors but behave as a partial agonistic effect. Okay, now what happens as a result of this? Now the first concept you need to understand that a partial agonist in presence of an agonist, of a full agonist, sorry, of of a complete agonist will behave as an antagonist. Okay, this is the first concept you need to get into your heads, because in your CNS portion, because a partial what happens is that suppose there is a drug A and a drug B. Okay, this is a partial agonist, this is a complete agonist. If both are acting on the same receptor R, now when B binds, the effect is suppose 100 units, and when A binds, the effect is say 20 units. So there is this gap of 80 units which is being created, and these 80 units of effect are absent. So that's why we say that a partial agonist in presence of a complete agonist will behave as an antagonist. But again, if this drug B was not there, only A was working on receptor R, despite it producing only 20 units of effect, still since B is not present, this 100 units are not being produced, and so it still is having some agonistic effect. So we can't in that case say that is behaving as an antagonist. But when this full or complete agonist is present, we can say that it will behave as an antagonist. Okay, the second concept is that beta blockers with partial agonist effect are least likely to cause bradycardia, again due to partial agonistic effect, and they also have negligible effect on lipid profile. They are not effective in prophylaxis of migraine because they will have a partial due to partial agonistic effect on beta 2, which results in vasodilatation. You know the what is the actually the etiopathogenesis of migraine? It's because there is something compound CGRP. Okay, CGRP ligand is released by the serotonergic nerve endings, and these will act on the meningeal blood vessels, and CGRP is calcitonin gene related peptide, and when CGRP acts on these meningeal blood vessels, it will cause vasodilatations, and due to the stretching of the meninges, that is when we get that pain sensation. Okay, and so these drugs will cause beta 2 mediated vasodilatation, and hence they are not effective in the prophylaxis of migraine, and that is why non-selective beta blocker like propranolol is used for the prophylaxis of migraine. Okay, the next concept that you should know is that beta blockers with membrane stabilizing effects are not used as topical agents in glaucoma because of the risk of corneal damage. This is very important, you should remember. That is why you don't hear giving topical metoprolol or topical pindolol in glaucoma. And yeah, that's more or less it. Again, one more point I forgot to mention is that uh, beta blockers with intrinsic sympathomimetic if not used in myocardial infarction prophylaxis. Again, due to beta 1 partial agonistic effect. So please don't say that these cartiolol and celiprolol, these are um, partial agonists. Okay, these are beta blockers, but which may have partial agonistic effect. In certain cases, it may behave as an antagonist as well when there is a complete agonist present, but in certain cases it may behave as a partial agonist as well, and so in these cases it's better to avoid them. Okay, that is what I'm trying to enforce here. And there is one little mistake I made in my previous video, that is tilisolol. I said it's a potassium channel blocker. Please correct it. It's not a potassium channel blocker. It's a potassium channel opener. And whenever potassium channel opens, there is vasodilatation. Okay. Sorry for the mistake. Yeah. And later you will come across a variety of drugs used in angina and hypertension, all of which are potassium channel openers. Okay. And which cause vasodilatation. Anyway, so yeah, thank you.